Ladies and gentlemen and everyone, it gives me enormous pleasure to welcome you to this special International Women's Day webinar looking at perimenopause and menopause, survive or thrive. My name's Julie McCrossin and it's my enormous pleasure to be your host this evening. And our evening is formally hosted by Wolper Jewish Hospital, Friends of Wolper, and our partner this evening, the Women's Health and Research Institute of Australia. And I've just got some quick housekeeping for you as a few more people join us. Most importantly, your questions are really welcome and you can send your questions through the Q&A throughout our webinar. We've also received a very large number of questions prior to our webinar. Obviously, we can't answer them all, but we're going to do our living best to do so. And we will be emailing you links to evidence-based information on all the key issues after tonight's webinar, along with a feedback sheet and also a recording of tonight's webinar. And that recording will be available on the Wolper Jewish Hospital website and will be shown within the hospital as well. Well, ladies and gentlemen, our questions will be monitored tonight by Dr. Alan Schell, General Practitioner. And as I said, he'll sort through them, see the key themes, we'll answer as many as possible, but not personal individual questions. We'll go rather to general viewpoints. Well, it's my great pleasure now to welcome Dr. Alan Schell, a great friend, not only of this webinar series, but of the Wolper Jewish Hospital community. So over to you, Alan, welcome.
Thank you very much, Julie, and certainly welcome again for being our moderator tonight. And this is a very important topic as it's going to affect, according to the Australian Bureau of Statistics, approximately 1.65 million women in the age group of 40 to 60, which this topic is covering, with the median age around 50. I think that's a very important topic. As a GP, we get questioned many times a week about issues around the perimenopause and menopause, and tonight we certainly have some very professional and well-versed in the topic panelists, so that's going to be a joy. I also would like to let you know that Wolper is now celebrating 60 years being in the Eastern Suburbs community, serving the Jewish and the general population, particularly in becoming a premier work hospital for rehab, people after hips and knees, and also slow rehab for those people who are wanting to sort of pick up a little bit after a major operation or illness. We have a very well-established palliative care program that we work with the hospice and other groups around New South Wales. And of course, we look after general medicine. So in the tradition of that, we've also been running the Wolper Wellbeing program for over 18 years. And I'm happy to say I've been a long time part of that. However, I'm going to take a bit of sabbatical after 18 years, and I'm going to introduce my good colleague, Dr. Peter Stein, who will be taking my place this year, and I'm sure you'll find him equally knowledgeable and very interactive in tonight's meeting as well. The rest of the year, we have another 4 programs organised, and particularly around men's health as well, and issues around cardiology, deafness. So I'm sure that in due course you'll receive in your email box. We only use your email for letting you know about Wolper events. We don't sell them or give them away to anybody else. And we look forward to seeing you again this year. Of course, we are partnered tonight by Dr. Lauren Kite, who's representing the Women's Health and Research Institute of Australia. And with that, I'd like to introduce Lauren to say a few words about the Institute. Lauren is a very well experienced obstetrician, gynaecologist and pain medicine specialist. Thank you, Lauren.
Thank you, Alan, and thanks for having me along tonight. So it's my job to just do a quick overview of what we do at Women's Health and Research, or WIRIA as we abbreviate ourselves to. So WIRIA is a multidisciplinary practice with a focus on women's health. In the practice, we have 5 gynecologists, Professor John Eden, who's talking later, Professor Thierry Van Kai, Dr. Yasmin Tan, Dr. Karen Chan, and myself, and I also offer obstetric services, and Dr. Amanda Beach, who is an endocrinologist and obstetric medicine physician. In our allied health team, we have 2 pelvic physiotherapists, 2 osteopaths with a special interest in pain, particularly pelvic pain, and a psychologist. We offer diagnostic ultrasound and procedural services on site. Amongst our practitioners, we have a variety of special interests. The hot topic of the evening, menopause, is the special area of Professor Eden, and he also sees patients with other endogynecology issues, including premenstrual dysphoric disorder and polycystic ovary syndrome. Pain medicine is a special interest of our practice, with both myself and Professor Van Kite dual qualified as specialist pain medicine physicians, and Dr. Chan also completing her training in pain medicine. So we see patients with period pain, chronic pelvic pain, vulval pain, pain with intercourse, and we have excellent support from our allied health team members. Dr. Tan is a specialist in pediatric and adolescent gynecology and also vulval dermatology. All our gynecologists offer surgical procedures, including advanced laparoscopy and hysteroscopic surgery. Dr. Beach, our endocrinologist, has special interests in obstetric medicine and in osteoporosis. And Professor Van Kite is a leading specialist in the management of Asherman syndrome, which, if you're not familiar, is scarring of the uterus that can lead to problems with fertility, particularly. At Wiria, we're also involved in research, including some larger multi-site trials, and we conduct original research through the practice. So our website has a lot of resources for patients about the conditions we specialise in, and also resources for other healthcare providers. If you're interested in anything, please do take a look. Our main practice is on Bathurst Street in the city, and Professor Eden, myself and Donna, one of our physios, also see patients at Cogra. We're affiliated with the Prince of Wales Private Hospital and the Royal Hospital for Women at Randwick.
Thank you very much, Lauren. And I'm sure that you're all going to have a lot of your questions answered through the evening, and we will do our best to answer most of them if we can. But I'm sure some of the resources that you'll receive in the email post the event will assist you in finding some of those answers. So without further ado, I'd like to hand back to Julie, who will be managing the evening together with Peter and myself. Thank you, Julie. Thank you very much, Lauren.
Yes, thank you so much, Alan, and also Dr. Lauren Kite. That was an amazing overview of the issues that your institute deals with. Just before we get our panel on the screens and get going with questions, and if you've just joined us, if you've got questions, please put them in the Q&A, and we're going to do our best to answer as many of your questions as possible. But first of all, we're going to have some poll questions, and I'll ask our man in cyberspace, Michael, to put up the first audience poll question. I read out the question, you answer it, and then I give you the answers. So number one, what is your age group? Up to 29 years, 20 to 30, 31 to 40, 41 to 50, 51 to 60, over 60. Could you just do a click? I'll give you a moment. Thanks, Michael. Let's see the results. So there you can see that everyone's over 31 and 36% between 41 and 50, 44% between 51 and 60, 18 over 60. Question 2, please. Where are you on your menopause journey? And you'll note on the bottom, not female is available. But at the top, haven't started yet, think I've started but not sure, definitely underway, I'm finished, postmenopausal, don't know, not female. Please make one choice. Thank you. We'll have the answers. Haven't started yet, 10%. Think I've started, not sure, just over 20%. Definitely underway, around 40%. I'm finished or postmenopausal, 26%. Don't know, 3%. Not female, 2%. And thank you to those gentlemen who took an interest in the lives of the women in their lives. Thank you very much. Our next question, please. Symptoms. Which of you experiencing? You can mark more than one. So this is experiencing it now. Hot flashes and or night sweats, insomnia, vaginal dryness, weight gain, depression, anxiety, memory problems, reduced libido or sex drive, heavy or prolonged periods. You can make more than one choice. Just give a little longer, Michael, for this one. . Thank you. Let's see our results. Hot flashes, or flushes I often call it, night sweats 56%, insomnia 50%, vaginal dryness 38%, weight gain 60%, depression 30%, anxiety roughly 50%, memory problems 50%, reduced libido or sex drive nearly 60%. Thank you very much for your frank answers. Our next one. Which of these symptoms are the most disruptive to your life? I won't reread them, they're there, slightly in a different order. You can mark more than one, but which are the most disruptive? Thank you, Michael. Most disruptive, 20% hot flushes, 17% insomnia, only 4% vaginal dryness, 16% weight gain, 2% depression, 13% anxiety, 14% memory problems, and reduced libido or sex drive, 12%. I think we have just one more question, please. Weight. What has happened to your body weight around midlife? Just one answer, please. Nothing. My weight has stayed the same for years. I've lost weight. I'm not sure what choice 3 means. I'm so sorry. My weight has stayed the same, but my waist has increased. I have gained weight, especially around my waist, and can't seem to lose it. So if you could answer the ones that have full sentences, please. Thank you. So 11%, nothing, my weight's the same. I've lost weight, 7%. My weight has stayed the same, but my waist has increased, 15%. I've gained weight, especially around my waist, and can't seem to lose it, 67%. Look, thank you so much, ladies and gentlemen. And obviously that lets you know a little bit about each other, but it informs our panel. And I'd now like our panel members, if they would, to turn on their cameras. And I welcome Associate Professor John Eden, Vicky Graham, and Professor Lauren Williams. And I'll give them a full introduction as I introduce them and ask them questions. But this is deaf sign clapping. Do you mind just clapping because you're here? I'm asking you, the panel, to show enthusiasm for each other. This is deaf sign clapping. It's not silly. Thanks, Ellen. You'd be amazed how much people crave feedback and connection, even in the land of Zoom. And could I acknowledge we have 2 Queenslanders here, Professor Lauren Williams and Vicky Graham, and to you in Queensland and to anyone in northern New South Wales or even affected by the dreadful rain here in Sydney, just a special mention. Well, ladies and gentlemen, I'm going to, because we have, I think, John Eden, you may agree, in that series of answers, a considerable number of people experiencing quite significant symptoms. We are going to spend, I think, a good deal of time with you, Dr. Eden, and I wanted to introduce our other 2 panel members first to indicate to our audience that I can hear some noise there. So if someone's got their mic on, if they could keep it off until they're speaking. Thank you. But I just want to indicate to our audience that we will be looking at some general advice on how to thrive and manage our experience and transition of menopause when we speak to our 2 guests from Queensland. So could I begin by welcoming Vicky Graham, if you could turn your mic on, Vicky. Vicky is an accredited exercise physiologist, the co-author of Menopause Made Simple, and she delivers a women's wellness midlife program, a 12-week program that is evidence-based. So a big welcome to you, Vicky. I mean, I'll talk to you in more detail later, but your message is really, we need to keep strong, keep coordinated, and to move. Is that the guts of what you're going to be talking about?
Yes, I love how we've been talking about thriving in menopause, definitely. And, you know, as an accredited exercise physiologist, movement is my medicine. So, you know, we know that movement can be one of the menopausal women's best friend for a range of different reasons. And we'll talk about that as we go through. But absolutely, I think it's about becoming, being proactive during this stage. Midlife can be a time for us to really look at where we are and really set ourselves up for thriving in the second half of our life.
And I guess, Vicky, because I've already had an indication from John Eden and from you that bone health and falls prevention are so critical as we age, and that falls is in fact a very deadly experience for many women. And so looking at the role of exercise in maintaining bone health and the capacity to not fall, if you fall, I guess to roll and not break, will be something we'll come to you about later. So thank you. And let me also introduce Professor Lauren Williams, Professor of Nutrition and Dietetics at Griffith University. And Lauren did her PhD at the University of Newcastle in weight gain during menopause. And you're currently writing your 5th book, which is all about women approaching menopause. So managing weight, you want people to realise that this weight gain, this change in body is something we do need to take seriously and to be proactive about doing something different, or we're going to gain weight. Is that the nub of it?
Yes, absolutely, Julie. And well, hello, everybody. I'm really glad that I could be here this evening, given the number of you that are really experiencing issues with your weight, and particularly with that gain of weight around the waist. And I want to be able to pick up on that prevention message, the thriving, and help those of you who have yet to experience the menopause to prevent that problem. But even if you're many years postmenopausal, it's not too late to do something about it.
Thank you so much. And yes, the numbers there in our poll in relation to being concerned about weight gain and weight around the waist was very significant. So thank you. Well, ladies and gentlemen, let me come now to Associate Professor John Eden, a gynaecologist and a reproductive endocrinologist. I'm going to ask you to explain what that means in just one sec. So John is the director of the Sydney Menopause Centre at the Royal Hospital for Women in Sydney and the founding director of the Women's Health and Research Institute of Australia. And of course, we heard earlier from Dr. Lauren Kite. So welcome to you, John Eden.
Thank you. Glad to be here, Julie.
Let's explain reproductive endocrinology.
It simply means women's hormones. So I don't exclusively deal with menopause. I cover hormonal problems from little girls with puberty problems through to fertility problems. I actually have a particular interest in breast cancer, and I'm part of the breast cancer group at Prince of Wales, which I just love. And I often say to my oncology colleagues, yes, you cure them, but I'm the one who makes them feel good. So I've got the better job.
I'm going to dive into it, but I was trained in my school and uni education to get the definitions clear. So just in a nutshell, we're called perimenopause, menopause. What does it mean?
Yeah, menopause is probably the simplest one. It means no periods. It's Latin for no periods. So the definition that's been around for decades now is when the periods have been gone for 12 months. So it's a looking backwards definition. You don't know you've had your last period until 12 months has gone by. And there's no test that will confirm that in a sense. That so you can have a blood test that, once your periods have been gone for 3 months, that says menopause, then you could get your periods back again next month. So it simply means no periods for 12 months, basically. Make it a bit more complicated than that, but I won't. And the perimenopause are the years leading up to and including that last year of not menstruating.
And then the range of ages in which it occurs and where most women tend to cluster?
Yeah, basically the average age of last period in Australia is 51, but it has a very wide normal range. It's from 40 to 60, which is an extraordinary normal range. And I often talk to, women who are having irregular periods and hot flushes and maybe age 42, 43, and they think they're very abnormal and very too young for this to happen, but they're completely normal. And I do have another patient at the moment who's 58 and still menstruating, which she's not happy about, but we're going to do something to help her with that. But she's normal too. So there's a very wide range of normality.
Look, we spoke beforehand, as I did with each of you, and the bottom line is, from your perspective, is a large number of women have a terrible time and too few get help. And I almost have the sense too that when they do get help, they don't necessarily get the right help. So could you just speak to that? A large number of women have a terrible time, too few get the help they need. Can you give us the spread of experience and what proportion of women have a terrible time?
Yeah, it's the way I explain it to my patients is there's sort of 4 quarters. There's a quarter who have nothing. I don't see a lot of those. So their periods stop, a year goes by and they go, is that it? There's another quarter who have nearly nothing, maybe just occasional mild hot flush. Then there's a moderate category where they may have a flush an hour, may wake up twice at night. And then there's the horribilis, as the Queen said, the final quarter who it can be as bad as having 5 or 10 hot flushes an hour, day and night, waking every 30 minutes. And half of them, it never stops. It goes on forever. And when I say forever, I mean till the day they die. And so I have a practice full of older patients who are still having severe flushes.
Can I just come in there, John, because we've obviously seen in our poll a lot of people with symptoms. When you say it, for a lot of people it goes on forever, do you mean unless they get help from an appropriate clinician? Yes.
So if they have no treatment, we have lots of population studies, and that's what I'm quoting from. These are women having no treatment. So these are women who will have severe flushes from, say, the age of 50 until the day they die. But we have very effective treatments. No woman has to put up with that. And a recent survey showed that less than 1 in 8 women get any treatment at all. And the most popular treatment's an antidepressant, which I find distressing.
Although in some of the material I was given to read, some antidepressants at a low dose, I was told, can affect flushing.
Yes, they can take the edge off the symptoms, but they also have, in some women, catastrophic side effects, including loss of orgasm. And, women going through menopause aren't feeling wonderfully sexual, and to give them a drug that blunts their orgasm is not a great idea in my estimation. It has its uses. There are certain situations. I mean, women with breast cancer, for example, they can't take hormone replacement. So we sometimes use other things for women who can't take estrogen. Yes, it's at the bottom of my list. Yeah.
No, let me ask you as a question. When I looked at that poll and the women identified the symptoms that are causing them distress, there would seem to be quite high numbers there. Would you say that we've got an audience where a significant number of women are having difficulties?
Yeah, I looked at the numbers. It's probably fairly average. We didn't actually ask them how bad it was. It's about half get significant symptoms and half don't. So my impression was it was about 50-50. But it's not.
The poll, the second version on the symptoms was about distressing, and the numbers were still high. But look, the main point I want to say is this: I want to offer thrive and hope from now on until we stop talking at 10 to 9. So
sure.
Let me go to what you said just a moment ago. I want to repeat it. No woman needs to put up with bad symptoms.
That's right.
We have safe and effective treatments.
Yes.
So a lot of people have asked about HRT. So could I go straight to you asking you, what is that? And in what circumstances do you consider it an appropriate treatment, and what are the pros and cons? Because as you know,
there goes the hour, people.
No, John, you're going to do it in a few tight minutes.
I'm going to do it in a few minutes, am I? Am I, Julie?
Yeah. So go for
oh dear. Oh, let me have a crack at. It's very challenging.
What is HRT? I'll break it down. What is HRT?
Well, yeah, HRT is basically hormonal treatments to relieve menopausal symptoms, and it does cover a fairly wide swath of things. So for many years, we've actually had natural estrogen for a very long time. It's called estradiol, and that's been available in Australia for at least 50 years. What we didn't have until fairly recently was natural progesterone, and so a lot of hormone therapies, certainly up to about, I'd say, 10 years ago, had some synthetic hormones as part of the mix. Now, and it's actually been the synthetic progesterones that have actually caused some of the side effects and problems. So, as a broad comment, women going through menopause mostly love estrogen. There are exceptions to that. We've got to watch it with migrant women, you can have issues. But in terms of getting rid of sweats, flushes, mood swings, a third get aches and pains, fixes all that as well. Estrogen is the sweet hormone of this story. But we've known for 50 years you can't take just estrogen alone if you have an intact uterus. The Americans did that experiment in the 60s. So if you give women estrogen only, who still have their uterus, about 10 years later, they had an epidemic of uterine cancer. I'm talking cancer of the lining of the womb, not cervical cancer. And then they went, oh gosh, of course, the estrogen stimulates the womb. Maybe we should have given some progesterone. In the 80s, we got a lot of regimens came out combining, at those days it was synthetic progesterone because that's all we had. But it worked very well in terms of protected the womb from cancer very, very efficiently. And most women were happy. Although about 1 in 8 will get side effects from synthetic progesterones. These are the same women who don't like taking the pill because the pill has synthetic progesterone in it too. And so it makes some women irritable, depressed, bloated, things like that. And then in the 90s and the early 2000s, we realized there was a trade-off if you use synthetic progesterone, that there's a slight increased risk of breast cancer, which has been catastrophized in my opinion, but a very small effect on breast cancer risk. But you had a lower risk of uterine cancer and even bowel cancer, interestingly enough, for some reason. But that caused huge controversy, and I haven't got time to go into detail about the American study that caused all that, but that's now become, in my opinion, an urban myth that hormone replacement causes breast cancer, and that's probably the single greatest reason why women are not engaging with doctors, because they're scared they'll get breast cancer if they take hormone therapy.
If I could just come in, John, you've given us a lot of information there, and I wonder if you can boil it down to this. There'll be women clearly listening tonight thinking, should I talk to my GP about whether HRT could help me? And if I do talk to my GP, what questions should I ask? And when should I ask for a referral to a specialist such as yourself? So could you just give us some simple guidance for women thinking along those lines? What do they need to talk to their GP about if they're thinking of HRT? And when is it appropriate to ask for a referral?
Yes, well, I think that a woman should always start with a GP. That's always the start point. And there are other treatments. I mean, again, times constraints, stop me from talking about other things. I mentioned in passing, for example, we have treatments for breast cancer patients that are quite effective for hot flushes too. I mean, nothing's nice to take hormone therapy, but there are some pretty good second-line treatments for women who can't. So there's always an option.
For a moment, if you could just come back to the question, what should a woman, when should a woman talk to her GP about HRT, and in what circumstances would you consider it the right thing, rather than the history? Could you give us some?
Yeah, that's hard. It's hard to give you a clear. It's more complex than what you realise you just asked. Then it's a very complex question. But the short answer is a woman who's having, in Australia, it's going to be most women having significant hot flushes. So if they're having flushes so bad that it's disturbing their sleep, they can't work. There are some jobs, for example, where it's very hard to have flushes and work. And it's often health professionals actually wearing all the PPE gear. Trying to have a hot flush in PPE gear, it's terrible. And the actual outfit will actually magnify the intensity of the hot flushes. I see quite a few lawyers and barristers. I mean, the outfit barristers wear is terrible. It's hard enough being a female lawyer, let alone wearing an outfit. So the symptoms are bad enough. That's what takes most women to their GP. Now, I think it's fair to say that some GPs are not comfortable to talk about this issue. They feel they've been de-skilled. And if that's the case, then they should refer them to, usually it's a gynaecologist, but not always. There are some, certainly in many general practices, there are doctors, often female doctors, who specialise in women's health, and they could refer them to someone who knows something about menopause.
But just for our audience, the reason I'm coming in so strongly on HRT is that in our many questions, many of them were about HRT. So we thought we'd give the audience what they want right at the beginning. But again, if I could, when I spoke to you, you said more women die of falls. than breast cancer as a result of taking HRT. And that's really stuck in my mind because, of course, a lot of people, women, fall over. But as a way of giving a message to our audience, if a woman came to you with those quite severe symptoms you outlined, and you believed that hormone replacement therapy of some kind was the best treatment for her, and she said, I've heard it can increase the risk of breast cancer, what do you say to that woman?
Oh, dear, Julie. That's a 20-minute answer. That's very hard to condense it down to a few lines online where I talk about that for nearly 30 minutes. The short answer is that breast cancer, like many other chronic illnesses, we actually say it's not a thing you suddenly get. It's a chronic illness like heart disease, diabetes. And in fact, the seeds are sown in the first 20 years of life. I mean, I've written, be interested to see what Lauren thinks about what I'm about to say next, but I've written quite a few papers on cancer and diet. And when you look at veganism and the traditional Japanese diet, these things only really have a protective effect if you consume these diets as a child and up to the first 20 years of life. And there's actually programming of your stem cells going on. It's extraordinary. And what we see, and by the time we get to 50, if you're on the way to getting a breast cancer, you're on your way to getting a breast cancer no matter what hormones you take. And what the evidence basically says is things like hormone replacement or even the pill, I'll throw that in as well, don't cause breast cancer. But what they may or may not do is determine when you get breast cancer. And so one way I put it to patients is if you're destined to pick up say a 3 millimeter mammogram detected breast cancer at age 70, but you took the American synthetic HRT that was all the controversy 20 years ago, say you took that for 10 years, you may find your breast cancer at age 69 rather than 70, right? But you're always going to get it. And that's not how they tell the story out there in, media land.
Thank you very much, John. And I just want to let you know, I'm experiencing you coming in and out a little bit with reception. I can understand you, but Michael, our Cyberman, may talk to you through chat. Could I ask Dr. Lauren Kite just to turn on her camera and her microphone for a moment? And just before I leave HRT, and I'll come to Alan Shell for our first question from the audience, any comments you would make about HRT to the women listening? Only if you feel it's something you would like to add or summarise.
Oh, I think I would just echo a lot of what John's saying and say that our evidence since the big American trial that's caused all this controversy is very reassuring, and particularly with the newer body identical hormones that we use, the evidence seems to be that they're quite safe. And yeah, you're probably not going to get a breast cancer that you weren't going to get otherwise.
That seems to be the key message. The other issue that I hear discussed by women is whether I should take it for longer than 5 years. Is it possible to give a straightforward message about that issue?
Yeah. Yes, I think, well, I hope John would agree with me that we would say, yes, you can definitely take it for longer than 5 years, particularly if you're one of those unfortunate women who do suffer from severe symptoms for the rest of your life. There's no reason that you should suffer. And there is benefit in terms of using hormone therapy up to the age of 60 in terms of reducing your risk of osteoporosis, your risk of cardiovascular disease, your risk of bowel cancer, your risk of dementia, and your risk of all-cause mortality. So there's a lot of pros to it, as well as treating your menopause symptoms.
Look, thank you very much to both of you. And I'll come now, ladies and gentlemen, to Dr. Alan Shell, our question monitor, and we'll hear another question from the audience. Thanks, Alan.
Yes, obviously we said that HRT was hot on the block, and I think that we need to ask issues around the bioidentical hormones, if that exists, and also the use of magnesium supplements, etc., that people can buy over the counter in well-meaning naturopathic services. So I think that's been quite a few of the questions. Do you have any comment on that? Because obviously people are being informed by a natural therapist and they believe that you shouldn't be taking hormones, but we've got some bioidentical ones. Has any research been done on that that may be more confusing or may be helpful?
Can I come to you, John Eden, please?
Yes, actually, our group looked at some. Well, let me define what it is first of all. But bioidentical is a term that's been made up by a bunch of doctors and chemists. Really, it's an invented term. But what they're referring to is handmade natural hormones. So, they actually are drugs. We're talking drugs here. These are not like herbs or a supplement. So we're talking estradiol, testosterone. We're talking progesterone that a chemist hand makes in their chemist shop, and so on. Now, the problem here is that these things are not tested, and our group has actually published a number of women who develop uterine cancer following the use of these products, for example, and this is well written up. And it's really unnecessary, because we actually do have tested natural hormones. So playing with words a little bit, but I prefer to use the term body identical to get away from the bioidentical. But we have, I mentioned earlier, estradiol. That is the natural hormone that women make. We have it in tablets, gels, and patches. We have progesterone. We have the natural hormones. But the difference is these are tested, and we know there's safety limits and everything else, whereas the compounding, we don't.
And John, can I just ask, when you say we have them, would your advice be to women watching tonight who might be considering, learning more and considering taking some of these treatments, that they get a referral to a specialist such as yourself or Lauren Kite? Or is it something that GPs are also prescribing?
Yeah, there's no reason. A GP can certainly prescribe these. In fact, I see it as my life mission to, as Alan knows, I'm very actively involved in GP education, and till COVID, of course. It's my life mission to empower my GP colleagues to do as much women's health as possible. The products we have now are actually very easy to use. They have low side effect profile. A knowledgeable GP can certainly prescribe them.
Thank you. Alan, another question from the audience, please. You're not on, darling.
Apologies. The other questions actually will probably come about with Lauren Williams speaking and with Vicky Graham, because they've got a lot to do with prolapse, got a lot to do with issues around exercise, and certainly many questions about how do I get rid of this overweightedness, which approximately, something like 60% of people answered as being a serious problem for them. So I think that we'll probably have some longer questions, and maybe Peter can answer those later on.
Thanks a lot, Alan. So if I may come to Vicky Graham first. Sorry, I beg your pardon, to Dr. Lauren Williams first in relation to the weight management. And just a reminder that Dr. Lauren Williams is a professor of nutrition and dietetics at Griffith University, and managing weight in menopause is your thing. Just explain to us why it's dietetics and not dietitian. What's the significance of that term?
Oh, so I'm a dietitian and my practice is dietetics.
Okay, great.
So people are doctors and their practice is medicine.
Look, you said earlier that we change during menopause. Women's bodies change. They change in body shape and in composition. And this is a serious health issue. So explain to us why it is so serious. And then secondly, people are clearly asking for guidance and help. And then I'll come to Vicky as well. What can we do about this weight matter?
That's a great question and really important. It comes back to the hormones, and one of the hormones that John mentioned earlier was estrogen. And I'm talking about women who aren't taking HRT. So when you're not taking hormone replacement therapy and you get to menopause, and it's been 12 months since your last period, then you don't tend to have the previous circulating levels of estrogen anymore. So when you haven't got that estrogen, your body programs fat, like where the fat is laid down, differently. So before menopause, estrogen tells your body, for women, to get laid down on your hips and thighs, and that's why women are largely pear-shaped. Then at menopause, without estrogen, you actually don't have that message anymore, and the fat is laid down around your middle. So it's a body programming thing that estrogen is no longer there to do. So that's why you go from being pear-shaped to apple-shaped. The consequences, if you think about the other group, our other half, men, when they gain weight, they're apple-shaped anyway. So women unfortunately pick up some of the characteristics that men suffer from after menopause if they gain weight, one of which is being at risk for something like heart disease. The more weight you have around your middle, the more that you are at what we call metabolic risk for metabolic diseases like type 2 diabetes, like heart disease. So people often think that heart disease is a male condition, and certainly in younger men it is. But after menopause, women really catch up and overtake.
All you have to do is go into a cardiac ward, which sadly I've had to do on a number of occasions in major hospitals, and see how many women are in the beds to know what you're saying. I guess you believe it is possible to take action to prevent menopausal weight gain, and I'm assuming to manage it if it's already occurred. Give us the hope. What makes the difference for women who actually manage to do it? Because so many women are struggling with this, aren't they?
Yeah, look, and you mentioned earlier my PhD, Julie, and what I did in my PhD was study what happened in women, 14,000 women in the Women's Health Australia study, what happened to them when they did nothing special. And 40% of women gained quite a bit of weight across the menopause transition. And then 60% didn't gain weight. So I wanted to study the difference between those two women. And subsequently, I've conducted programs where I've used the things that I observed and tested them in what we call an intervention. So where you put equal numbers of people in one condition, the ones that get the intervention versus the other. And the intervention was actually only 4 sessions with a dietitian and 1 with an exercise physiologist. And I'm sure we'll hear from Vicky how important exercise is. And I'd really like to emphasise that both exercise and diet are really important in this space. But we manage.
In a nutshell, what made the difference? Where's the hope?
So the hope, the main thing in terms of diet was what most Australians don't do, and that's eating enough vegetables. So the women that had 5 serves of vegetables a day were the ones that got the weight off to 12 months. And then the second 12 months, we did nothing but watch them, and those women kept it off to 2 years. The other thing they did was 10,000 steps a day. So that's where the physical activity comes in. That was in our intervention.
Lauren, just before I leave you, I have, despite emceeing a million things on health, have been diagnosed with diabetes recently. And an amazing thing came into my life called a care plan. And my GP was able to draw up this amazing chart, and I was able to take a comprehensive approach to my situation. And I won't go into my personal story, but I'm taking it seriously. And after I spoke to you, I thought, I wonder if only we could have a pre-diabetes care plan.
Lovely, Julie. I think that is a great problem, that a lot of our healthcare system is really aimed at when people actually have a condition. And the people that I've studied would have preferred getting the information earlier, in that couple of years before diabetes actually develops, in that pre-diabetic phase. And I think it would be wonderful if Medicare focused on, if someone had a condition like pre-diabetes, or if women were having difficulty at menopause, if they could have the same sort of care plan and then access to allied health services that brings with it, that would save the government a lot of money down the track in treatment.
Lauren, help me to remember that we must come back to bone health, but I want to come now, if I may, to Vicky Graham, and a reminder that Vicky Graham is an accredited exercise physiologist and co-author of Menopause Made Simple. Vicky, what would you bring to this conversation about the weight management that can be so damaging to health?
Yeah, absolutely. Oh, I've just one moment. I've lost my lights.
You lost your camera, and that's tremendous. It's not common that at that moment things go dark and blank. And yet we live in an era of constant, unexpected change. It's now, of course, very watery. I'm sorry, I'm thinking, should I ad lib to time or give Vicky time to come back in? Vicky, I might wait till I see you. Ah, there you are.
Ta-da! It's really interesting to hear that body composition change, and I think that's a key factor when we're talking about these change in our hormones. One of the things that we do know, it's around the waist, and it is changing that body composition. That exercise is such a powerful tool that we can be using, and I think that's certainly one of the exciting roles I get to play in with women, is empowering them on how they can use. And I think exercise can be a word that's a little bit overwhelming for a lot of people. I prefer to sort of talk about movement and ways that we can use movement in our lives. But certainly it's increasing that muscle mass is, I think it's something we think about a lot when we're younger, but muscles really are less about what they look like and more about what they do as we get older. And we've talked a bit about falls prevention and the importance of that. So, you know, certainly
Can I just come in, because basically what Lauren Williams is saying, eat 5 vegetables and do 10,000 steps. Now, a day it was, wasn't it? 10,000 steps a day. From your experience as an exercise physiologist, what proportion of your patients or clients actually get up the numbers of steps and other activities you're giving them and sustain them? Because we want to thrive, like the title. So what's the key to thriving? What do we need to do?
Look, I think the key is meeting somebody where they are right now. And it's certainly about, you know, setting small, sustainable, I think steps are really important when we're talking about changing our health behaviours. A lot of the time we think we've, you know, want to achieve this, this, and this, but it just becomes overwhelming. So it's breaking it down, starting with some small steps. You know, we talk about the 10,000 steps, but certainly for a lot of people who are quite inactive or in a lot of pain, that's unachievable. So I think it's about meeting people where they are and supporting them to just move more in whatever that may look like.
And you also say manage your stress. How does that assist people to move and eat vegetables? What's this managing the stress?
Well, I think, you know, stress is one of the things we know that's increased in our society, but I think we underestimate the effect that, you know, high levels of this chronic stress are affecting and impacting physiologically, you know, within our body. So certainly within how we're working with women is looking at, you know, much more of a holistic approach where we are looking at how can we be intentional in managing stress that we have in our life, because it's layer upon layer. And I think if we're in this chronic stressful state, then when we're talking about changing behaviours, it becomes overwhelming. So sometimes that may be the starting point with people before you're even thinking about increasing your movement.
Thank you very much. If I could just have a quick comment from Lauren and also John. When you're dealing with your patients who are obviously coming to you because they have significant symptoms with menopause, if I could come to you, Lauren Kite, first. Do you bring in the issues of weight management and increasing exercise as part of the way you manage the symptoms, or are you more focused on, I guess, on pharmaceutical interventions?
No, very lifestyle focused as well. And I think that, I think medically we should be in every aspect of every patient's care. These are things that we should ask about at every consultation. Do you exercise? What's your diet like? And what changes can you make there? And as Vicky said, stress, I think that plays a massive part in so many health conditions, and we don't address it well enough generally.
Because what I've heard is that the feedback of the step counting and also the joining a group to walk are two factors that increase the likelihood that there'll be sustained physical activity. Would you have a comment on that, John, with the women that you observe who are trying to deal with these significant symptoms, the ones that do manage their weight and successfully keep moving. Have you noticed any success factors with them? What makes that possible?
Oh, gosh. Yeah, I do have a rather strange practice, so it's probably an unfair question because, you know, I see the ones who are shattered and miserable and come in crying because they haven't slept. You know, a big box of tissues is the first thing I check in the morning. So, yeah, I don't think that's, for me, I guess what I was listening to the other speakers thinking, the other thing we probably should just bring in is mood. And, you know, I get a lot of referrals from psychiatrists and women with severe mood disorders, or even say a mild mood disorder. They hit the menopause transition and it just goes terrible. And there are hormonal reasons for that. But I often find myself having a conversation around exercise and diet because someone who's depressed, often the first thing that happens is they go to carbs, and that's a disaster for lots of reasons, but especially for their mood. And again, they stop moving, and that's not good either. And often the perimenopause, severe PMT, something the Americans call PMDD, which is basically some women have such severe premenstrual mood disorder, they're actually suicidal, and they're the ones that I get to see. And they've nearly always abandoned their diet and their exercise. And when I bring it up, it's really interesting because I often go, oh, you're right, I felt so much better when I was doing vigorous exercise and my diet was clean. And you go, yeah. And you have to remind them that, as Lauren was saying, the whole package of lifestyle things is really, really important, especially for mood disorders, I think, and along with pharmaceuticals.
Thank you very much. I might come, if I may, to Dr. Peter Stein, who's our new question moderator, and this is his first go. Would you do this as soon as his face appears? If you could turn your camera on, Peter, to give him encouragement and warmth. He's a radiologist, and yet he's in a new role as a sort of health host. Over to you, John. What's your question? You need to turn on the mic. That's step one.
So are you asking me for a question?
No, sorry, Peter Stein, I beg your pardon. Peter.
Yes, thanks so much for the welcome, Julie. And I'm really enjoyed hearing all our specialists, panelists speaking. And I'm just picking up on something that you mentioned briefly, Julie, and I want to ask a question about something that hasn't been mentioned. That's the role of the social dimension to the therapies. So that is to say, your friends and your family, and then the activity groups, as Julie mentioned, walking groups as a good example, because quite a few of my middle-aged and later middle-aged friends belong to walking groups and several other social groups. And John, you talked about mood. So in a sense, the question is also about aging has a component of psychological and psychiatric illnesses irrespective of menopause. So and trying to sort those two out can be difficult. But could perhaps Vicky, I think, is the person who actually sort of alluded to it very much. Would you care to comment on the social dimension that helps people with talking to each other? They get themselves moving. They can discuss and bring their inner thoughts out with friends as they walk.
Yes, thank you, Peter. And who did you want to address that to? Sorry, I didn't catch that.
I thought I'd just start to Vicky. I think, as she said, when you're moving, when you're moving, you're talking and you're feeling and you're expressing your emotions as well as walking your body. But I'm interested particularly in what Professor Lauren and Williams and Dr.
Okay, thank you very much, Peter. I've got it. So, Vicky, do you want to kick off? What is our, really, I'm wanting people to offer hope and strategies, but
Absolutely.
the significance of mood.
Yeah, well, we know that, there's very clear evidence on the effect that moving has on our mood, on depression and anxiety. When we're looking at the statistics of people of what they were experiencing in the poll, anxiety was up there really very high. So certainly looking at, and it's also educating people about the effects that moving will have, not only just on our mood, but also on our cognition, on a range of different factors we're looking at. So I think it's really important that we're looking at that biopsychosocial kind of framework when we are looking at midlife and managing menopause. Because when we're feeling like we've got a little bit more motivation and our mood is not as low, then we're in a much better position to be able to make healthier food choices, to be able to look at putting some, strategies in place to manage our stress, or to be even in the position to go and speak to our GP and be proactive about, talking about where we're at, and particularly maybe where these, where we are in menopause, and whether these symptoms are high enough and severe enough that it needs to be, referred on for professional support.
Thank you. I'm going to come to Dr. Lauren Kite, if I may, for your response to that question. And if I could just add the notion of the sort of spiritual or identity impact of menopause on women. I certainly have had aware of people who kind of mourn the loss of the capacity to have children. They feel less of a woman, and the body shapes, body issues confirm, and the loss of libido. We'll come to that more specifically in a moment. So I guess your response to that, not just anxiety, but almost a kind of identity crisis, if that's not putting too high a term on it. Your thoughts there?
Yeah, that's something that I think we hear quite often, that people just say that they don't feel like themselves. One of the really nice parts of seeing people who have menopausal problems is the response that most of them have to the therapies that we suggest, and they come back and say, I'm me again. It's great. I love seeing people like that. In terms of the social aspect, I would say that is probably the most challenging part of looking after any patient who is isolated, because I think you can say go for a walk, and you can say eat more vegetables, and they're sort of doable things that you can do on your own. But then if you're isolated, and I just find that the biggest challenge, I think, with people, to get them out there, because there's less that I can do in that aspect.
If I could just quickly say, after I got my care plan for diabetes, I've been referred to the Heart Foundation, and there's squillions of Heart Foundation walking groups. I mean, I won't go on, but one of the top things was them getting me into group walking, because I was told the evidence was if I join a group, I'm much more likely to walk. John Eden, if I could come to you on that question, and perhaps particularly go to this issue of loss of libido and sex drive, because that came up very highly in our poll. And I think when it comes to not feeling yourself, and even the fear of losing your partner, can you talk to us what your patients talk to you about that?
Yeah, it's a very common symptom complaint. And I think the first thing is to normalise. I mean, there are some unreal expectations in the community. But when I run doctors' meetings on this subject, I often get Rosie King, who's quite an entertaining talker on the subject. And being a woman, an older woman herself, she's our age. She'll often say, I heard her once say to an audience of mostly female doctors on the same subject, she said, "Girls, isn't it nice that your husband finds you sexy?" And I thought I'd never get away with a comment like that, but Rosie did, and then she quotes figures, and we have lots of figures again based on population studies that many couples over the age of 50 are having enjoyable sex in a variety of forms, but anywhere between once a month to once a week, or sometimes a bit more. And they're really happy. And part of the problem is they sometimes read, or get on the internet or read what the expectation is supposed to be, and they think they're supposed to be having sex 3 times a week or something unrealistic. And in fact, it's I find often reassuring them, actually, using many of Rosie King's pointers.
But can I just quickly say, isn't the issue whether it matches the level of your partner?
Of course.
That's where the rubber hits the road, isn't it?
It is, but we can't really turn off the other partner's libido either. I mean, you're right, but but look, there are some women, there's no doubt, there are some women who have real problems that can be physical. I mean, Lauren mentioned, as a pain doctor, our group sees lots and lots of women who have painful intercourse from a variety of causes. That's a big killer, libido killer. We know from surveys by the age of 60, it's about 80% of women, if they don't have help from a doctor, will have painful intercourse. And most of it's very easily treatable with vaginal creams.
What do you offer?
That's what I'm about to say.
Get really specific. What, in a nutshell, what are you offering them?
Well, as I was about to say, we have vaginal estrogens that they can get from the GP. They don't even need to see a specialist. They're very easy to use and they're highly effective. And that fixes the vast majority of women. Now, we're left with a few others who have often injuries and nerve damage around childbirth and things. And that's where doctors like Lauren have a lot of expertise, and our physios, and we fix a lot of them up too. That's the good news. But then you also have a group who have no sexual desire, even though they love their partner, and they describe in glowing details how great their relationship is, but their libido just disappears. And in some of those women, a female dose of testosterone can be extremely useful. In fact, a lot of research has been done here in Australia. My colleague, Professor Sue Davis, has done a lot of that work, and our group at WIRIA has also done some work with testosterone. And testosterone is a normal part of a woman's hormones, and men make a lot more than women, but it typically peaks around the age of 30, and it tends to fall with age. It's not so much a menopause thing unless a woman has her ovaries removed, where they can suddenly lose their testosterone. But in most women, it falls with age. And it does seem to affect some women a lot more than others. And cutting a long story short, the product's easy to use. We keep the levels in the normal range. And when it works, these women, as Lauren just said, come back smiling, saying, I'm my old self. And it's not just their sexual function that's improved. Often there's an energy boost as well.
Thank you so much. Could I come to you, Lauren Kite, just for comments on how you assist people with painful intercourse or pain generally in the pelvic area?
Well, it depends on what the cause of it is. As John said, particularly women who are postmenopausal, simply using vaginal estrogen can be all that they need. We do frequently use the expertise of our pelvic physiotherapists, and that can be if muscles are overactive, and they also work on desensitizing when things have become too sensitized. So when touch is painful, for example, it sort of varies across the age range a lot in terms of what can be contributing. And we really do need to take a multimodal approach to addressing pain with intercourse, but we do have reasonable success.
And I guess Lauren Kite and John Eden, what concerns me is that both of you have said you get a lot of women who come to you with these issues, and it makes me think, my golly, you're probably only seeing the tip of the iceberg because they're the ones that get to you. And I guess, is there a place here for more public discussion, more GP education? Your thoughts there, Lauren?
Yes, definitely, 100%. Sex should not be painful, ever. Pap smears should not be painful. Using a tampon should not be painful. If any of those things are happening, then there are things that can be done to change that for you.
Peter, I'm going to come to you in just one moment for one quick question, and then I'll go over to Alan. But I just want to say, for your interest, I spent 5 years on a daily national radio program on the ABC, and we had a national talkback on the Friday that went for a whole hour. So we got people bringing from all over the country. So it was 5 years, it was a lot of Fridays. The two topics that actually blew the phones off the ABC, one was the loss of care in the hospital setting from nurses, and most of the callers were nurses, and that was just tragic, that they were feeling they didn't have the time to give the care that they wanted. And the other was sexual problems. You know, we had some people like yourselves with genuine expertise, and it was actually heartbreaking to hear the amount of how long people had gone without seeking help. So it's marvelous to hear you talking about this. But Peter, another quick question on another topic, please.
Yes, the issue of stiffness and anxiety seemed to come up in a number of questions, and I guess
did you say stiffness?
Body stiffness, yes. So I'm just interested in understanding. I think John suggested that there was a significant improvement with hormone therapy, and perhaps Dr. Kite also mentioned that. Have I understood that correctly? That the physical sense of stiffness in the body and sense of physical well-being may be significantly improved with HRT.
John Eden, do you want to respond to that, please?
Yeah, it's specifically around the time of perimenopause. So when the cycle's going up and down, the hormones are swinging, it's about a third, and it's very significant. I mean, some women, some will manifest this as a worsening of an existing problem. So sciatica may get worse, or carpal tunnel syndrome may get worse, or rheumatoid arthritis pain may get worse. For others, they develop almost like a fibromyalgia syndrome, that the whole body just is in pain. And I do get quite a few referrals from rheumatologists, because often the key is they go and see a rheumatologist because they've got joint pains and all the tests come back negative, and they go, oh, you're in menopause. And it disappears within usually 2 weeks of going on some estrogen. If the women don't take treatment, I find the symptom typically lasts about 2 or 3 years and then disappears. So it's not something we wouldn't use estrogen for, say, a 65-year-old woman who had body stiffness and was 15 years after a menopause. But for the younger women in the perimenopause, it's often the worst symptom. When they get this body pain, it's often the worst symptom, and they're amazed it goes away so quickly with some estrogen.
Thank you. I'm going to come to Vicky Graham quickly on this before I come to Alan for a question. And the reason I come to you, Vicky, is that you're an exercise physiologist. And I know from my own body stiffness, I've now got a granddaughter, and I want to get up and down off the floor. And I mix with a lot of grandmothers. And you'd be amazed how many women can't get up and down off the floor. And this, I mean, what does it mean for your sexual life? But it also interrupts your grandmothering. So what's your advice as an exercise physiologist if you're wanting to stay flexible and strong, either for sex or for your grandkids?
Well, you know, Julie, there is certainly our muscles can be strengthened at any age. We used to think that we lost our muscle because it was just what happened as we got older. We now know that that's actually a very small percentage of that. It's more that our lifestyle does change. So certainly some really simple body weight exercises we can be doing can, you know, certainly preserve a lot of this muscle mass and definitely improve it. And that goal of wanting to be able to keep playing with your grandchildren is a very powerful motivator for people of why, you know, I see them and they're referred into me because they're not able to do that, and it's affecting their quality of life.
And it is possible to get access to these exercises, guided exercises, even in groups through Zoom, isn't it? Because we don't know how long this epidemic's going to go on for.
Yeah, absolutely. And we've certainly been converting a lot of our delivery in virtually. And it's certainly to educating and empowering these women of what they can do, and knowing that, well, it doesn't have to be going into a big, overwhelming, scary, you know, gym that's completely off-putting for these women, that it can be some simple body weight sort of movements that can go a long way to be, you know, improving their quality of life and continuing to be able to do the things they want to keep doing, like you were talking about.
Thank you. If I could bring in Professor Lauren Williams, our nutritionist, is there any evidence that if you proactively manage your weight and try to stay in a healthy weight range, you're more likely to do what Vicky's telling you to do and get moving and keep your muscle tone going? Like, what's the connection between the weight and the exercise?
I think there's clearly a physical ability to move more. There's also the problem, as you get older, our muscles can start to fill up with fat cells, which means they don't work very well. And that just causes more fat cells to be laid down. So we want to really prevent that happening. And I'm not an expert in that area myself, but I think that's something really important to try to prevent. But getting moving and staying moving, when you are in the healthy weight range, it is definitely easier.
I can say, as someone who has been in walking groups over the years, you've got to keep up with your colleagues too, so it helps. But if we could farewell you, Peter, and you might find some new questions, and we'll go now to Alan Schell. Thank you.
Thanks, Julie. Well, I'm going to make one plug for Wolper. We run a Move Well program, and that's a good start. Has done hydrotherapy, and you can get a good start, Vicky, in our pool with easy exercises with support from water with some excellent physiotherapists. So local people, please consider. Two big questions I think are relevant, certainly to our medical team here, Professor John Eden and others, and to Lauren Kite, is the issue around uterine and breast cancer. People having had breast cancer in their late 40s, uterine hysterectomy, etc., oophorectomy included, and HRT. And some of the issues that, again, they often read in the media and negative thoughts, that they're quite averse to being considered for HRT. And the second one, of course, I think is quite an interesting question is, how about the cultural and ethnicity of that person? Because we have European, East Asian, Asian, and African, and they've all gone through different cultural thoughts about menopause, and that can affect your and my Western style of medicine talking to them. So the two parts were those people who have, for good reason, had to have uterine breast cancer and consider HRT and told they can't. And then you have the cultural and ethnicity of our population, which in Australia is becoming quite massive.
Thank you so much. John Eden, can you come in, please?
Yeah, well, breast cancer is one of my interests. I was actually paying particular attention to the second part of the question because we've actually done research in that area, but I'll come to that later. So we have a download on our website that looks at managing menopause after breast cancer. It's probably the easiest way of answering it. We have a whole stack of goodies. There's a number of medicines that were found by accident to help hot flushes, and we have 4 or 5 of them. And again, they're not as nice as taking hormone therapy, but they're pretty good. And we also have very effective treatments for vaginal dryness. Most women who've had breast cancer can use vaginal estrogens, but there are a couple of exceptions. Women using a class of drugs called aromatase inhibitors. But we have a whole host of goodies for them too. Sometimes Lauren uses laser. There's a thing called the CO2 laser that can be very effective for thickening vaginal skin. So we have very good treatments for women who've had breast cancer that are not controversial. There are a small number of women who've had breast cancer who probably can use hormone therapy, but the vast majority we do other things. Uterine cancer, actually the early stages uterine cancer we call stage 1 and maybe even stage 2, but certainly stage 1, actually they can use hormone therapy and that's not a problem at all. We have large trials on that. Would you like me to move on to the cultural thing while I'm in a groove? Yeah. It's we've looked at 10 different cross-cultural groups over the last 15 years, and as you might expect, there are big cultural differences. In broad terms, Asian women, and we specifically looked at Chinese women, Thai women, they have far fewer flushes than Caucasian women, but they tend to get a lot more headaches. The problems of vaginal dryness are everywhere, but it is fascinating how different we are and how we don't cope in different ways, because none of them cope, but they don't cope in different ways. So, I mean, all the different surveys, even amongst the average Aussie woman, has shown that most women don't know that vaginal dryness is a treatable thing. But amongst, again, every other cultural group, it's even worse. And some culture, for example, amongst the Asian women, one thing that shocked us all a bit was when we did some focus groups with our multicultural workers, a quarter of them actually admitted that sex was so painful, they told their husband they didn't want to have sex anymore and to have sex with other women, but don't tell them. And I can still remember, we all went, wow, wow, what a crazy answer. And then when we did some, we always have a debrief at the end, and we had about 300 Asian women in the room. And I said to the multicultural worker, please make sure you tell them we can fix this with a very simple vaginal cream. And so she started explaining. I heard this groan start and went right around the room. I can almost, even though I don't speak Cantonese or Thai, I could hear them thinking, what have I done? What have I done? You know, it's actually an easy fix, but they didn't know. And even worse than that, when we asked them, we pressed right into these questions and said, well, how would you like information given to you? And each racial group was different. Each cultural group was different. The Asian women were so shy, they didn't really want to talk about it. But if a doctor somehow got round to the subject and fixed it up, they're eternally grateful. There's a brief, I could keep going, but that's a brief, there are differences.
But it's so moving. Can I come to you, Lauren Kite, on this question? I guess it is, what more are we going to do to address to have a bigger and more common public discussion, and to do it in such a way that it's inclusive of our amazing multicultural society? Because we're talking about suffering here, aren't we? Really terrible suffering.
Do you mean in terms of pain with intercourse?
Well, I guess it, I mean, yes, with that, but more the question of is enough happening among, and what is the role of yourselves? I mean, you're from an institute on women's health, and we know there's Jean Hales in Victoria. They have a website. You've got a website. I'm not underestimating the communication challenge here, but this is just over half of the population. And the picture one hears from yourself and John, and I understand you're seeing that proportion who I referred to you, but we're pretty confident there's under referral. It seems to me there's a lot of suffering going on and insufficient public awareness and communication about it.
Yeah, I agree. I think there are a few things that need to be done differently. And from a medical perspective, I think our focus on women's health needs to be stronger in medical training. So in university for medical students, even in our own gynecology training, it's changing, but there hasn't historically been such a strong focus on managing pain, particularly short of a few particular treatments. And then more broadly in the community, I think that's changing a little bit, and that's probably to do with more people willing to stand up and say, I've had this problem, and particularly with social media, with people on Instagram saying, this is my story, and then other people following along with that. I think it's making a difference, but it'll take time. From a more sort of focused perspective, I think a lot of the time, as John said, people are shy and they don't, or they're embarrassed and they don't want to bring these issues forward. So us being proactive and asking, a lot of the time I always ask people about intercourse when I see them, and they wouldn't have mentioned it, but when I ask, they say, yeah, I can't have intercourse, it's too painful. So it's us being professionals and asking these questions so that we can get the right information.
Thank you so much. We're coming very close to time, but Peter Stein, do you want to ask one more very quick question, because you are going to be our question host for the rest of the year?
Yes, hi Julie. I'm just having trouble starting my video.
Well, give it to us orally.
I think you might have switched me off. Can you switch me on? Maybe
no, I don't have that power.
No, somebody switched me off. Hey, look, I feel much better now. Yes, just as a quick comment, there was several of the questions related to bone density, both in terms of HRT. It's obviously a part of general health, and I just want to put a little comment in for myself about is there a useful role in the measurements, DEXA measurements, so for example, do they help motivate people and focus them on the nature of the problem? What's the role, the management of bone density? Obviously, John, and I'm sure Professor Williams would have some thoughts on that too.
Thank you so much, John Eden. Bone density, how significant an issue is it, and what can we do to stop women falling and breaking?
Yeah, I love bone densities. I mean, my view is everyone over 50 at least should get a bone density, male included. I've had my bone density, and it's a really important part, and it's a great motivator. One of the things we learned a long time ago with twin studies, the Garvan Institute, of course, one of the great leading lights in osteoporosis in Sydney and Australia, even around the world, and they had a big twin study that they did over 2 decades ago. And one thing I never forgot, when you look at it, because twins allow you to look at genetic versus environmental, I won't go into the details, but basically they found that about 80% of your bone mass is genetically determined. So the bottom line is you can do everything right and still get osteoporosis, and do everything wrong and never, or do everything wrong and never get it. So I'm always amazed at the very fit people. I do see some very fit people who are really disappointed when they get a bone density and find they have established osteoporosis. Often with a fit person, say a triathlete or someone like that, is they get a pain in their back and someone does an X-ray or a CT and they've got a crush fracture in there, usually the middle of their thoracic spine, and they're followed by a bone density, and they're horrified to think that their healthy lifestyle and all that exercise they did betrayed them, is how they see it. And I say, no, that, if you didn't do all that, you'd be far worse, but sometimes you can do all the right thing and still need some pharmacological help. But also, we also know about 1/3 of Australians are vitamin D deficient. It's just everywhere. And I look forward to the day we put vitamin D in the food chain myself. I'm not sure what Lauren thinks about that one, but we probably need to. It's an epidemic, vitamin D deficiency, amongst a whole host of other bone nutrients that are missing. But yeah, the osteoporosis is a disaster. It continues to be a disaster in Australia. The first symptom is a fracture. It's not just an ache and pain. You bust a hip or you bust your back, and it's largely preventable with a mix of all the people we've got around the table here, getting your nutrition right, getting the exercise right. And actually getting exercise right is really important, because if you do have a fragile back, you need to do some weight-bearing exercise, but you do the wrong exercise, you can give yourself a fracture. But we also have a range of therapies. I'm not going to dwell on them tonight, but interesting enough, hormone therapy has made a big comeback as a treatment and prevention agent for hormone therapy because of some of the side effects of some of the bone drugs. So I certainly have patients where we use some sort of hormone therapy as part of their treatment for and prevention of osteoporosis.
Thank you so much. And Lauren, could I just bring you in and just give me a quick definition of osteoporosis and what causes it, just so we don't assume everybody knows. Could you do that, Lauren, please?
Sure. I don't know about if I can do the definition.
Oh, I beg your pardon. I meant Dr. Lauren Kite.
Yeah, that's what I wanted. Yeah.
I'm so sorry.
I'm happy with that.
My eye line, but of course it doesn't work in Zoom. My apologies. Dr. Lauren Kite, please. Just a definition. We've talked about it. We haven't defined it.
So it's basically a loss of bone density. And there are varying degrees. So there's a normal range of bone density, and then you can be a little bit under and you could be osteopenic, and then significantly under and you're osteoporotic. And that means your bones don't have the same structural integrity. So you're more prone to fractures.
Look, it's time to go. Can I just ask you, Lauren, and also you, John, but with great brevity, because we always finish on time. Lauren Kite, is there a topic we've missed of significance?
I think we've done a good job tonight in covering, in terms of menopause. Maybe problems with bleeding around menopause would be worth addressing another time.
And in essence, what that problem is you're referring to?
So irregular bleeding, and particularly very heavy bleeding, so flooding bleeding. You shouldn't have to put up with that. If that's something that you're experiencing, then you can certainly have some very effective treatments for that.
Thank you. And John Eden, is there a topic we've missed that we should just put on the table?
No, I don't think so. But I did have a little thought on what we were talking about earlier with culture and reasons why this isn't talked. It's the problem is that I think Australia's become very conservative when it comes to menopause. In the 90s, it was a hot topic. You couldn't shut people up talking about menopause. But in the last 20 years, I find that my talking to mainstream media in particular, most of the journalists all the journalists talk to a female, but they're usually around the age of 30. And if I go menopause, they often cringe. I've seen them physically cringe almost as much as saying the word vagina. In fact, I once got a lecture from a journalist about, you can't say vagina on Channel 9. And I couldn't believe it. And, because it said vaginal dryness, and she got highly offended at me using the word vagina. And I had to sort of pause and say, you do realize I'm not swearing. That is actually the medical term. It's called a vagina and it's okay. We teach children at school, it's a vagina or a penis, and you've got a university degree in communication. What are you talking about? And I was given this lecture how we can say breasts.
I must wind you up for time reasons, but I want to reassure you I was a co-commentator for Live to Air on Mardi Gras at the 6:30 to 7:30 time slot, and labia was mentioned. There were a lot of labias marching, and they chose to go to Latin, but the visuals explained what we were talking about.
Yeah,
okay. Ladies and gentlemen, I'm going to thank you from me, but let me hand back now to Alan Schell to close. But Alan, just before I hand over to you, working with you is an absolute dream. I love Peter Stein, but we love you. And we're going to miss you terribly, and we look forward to your return. But I'll hand over to you now.
Thank you. I'm not going to flush, but I do appreciate that, and it's been my great pleasure. And I can only say that this is one of my pet topics. I was a man of the 80s in general practice. I was the family planning and the menopause. Went to a Gynaecologist conference and one of their classes, and realised that the other 5 women in the class had no idea about menopause or perimenopause, and I did. So I was very thankful for being well educated in our group of hospital. To Professor Williams and to Lauren Kite and Vicky Graham, thank you very much for being here this evening. We really appreciate. We couldn't answer all the questions, but I know that many of the questions remain unanswered. So for people who are registered, we will send you as much resource information on Warrior and others, Prince of Wales, Gene Hale, etc. I know that walking and exercise with COVID, my wife and I, you've got to have a good partner if you want a good walk as well. We've done our 10,000 steps. We got fitter. We watched our diet. So all those things help. So thank you, Vicky and Lauren, because we do that. And I can only recommend it to everybody out there. We, of course, going to have another session in May, which will be on deafness, Meniere's disease and related issues. We didn't talk about dementia, but I know that being fitter and being having a good mood is obviously something that will reduce the risk potentially of dementia, but it's something that if you haven't sought assistance, please come and talk to people like the ones that are here tonight who've been fantastic. And I can only say it's a goodbye to everybody for the moment. Hand over to Peter Stein. Wish you all well and know that this has been recorded, is available on the Wolper website. And I can only say goodbye and hand over to Peter, and thank you all for being here tonight. It was fantastic. And thank you very much also, Julie, for always. Thank you.
Ladies and gentlemen, as we close, I'll give the close. Let's wiggle and wave for the marvellous Alan Shell, and we look forward to his return from sabbatical. And ladies and gentlemen, that's the end of our webinar this evening. Thank you for being with us. Thank you.
Thank you. Thank you.
Thank you.